Good afternoon and welcome to the CAQH Index webinar. We are going to hold just one more minute as a number of people are joining us. Please be patient. We'll be back with you in just a moment. Thank you. Good afternoon and welcome to the CAQH webinar for this 2016 CAQH Index. My name is Karen Waller. I am the Communications and Marketing Director for CAQH, and I will be the moderator for today's webinar. Before we get started, I'd like to review just some housekeeping details for all those listening today. Today's session is being recorded. You will receive an email with a link to the on-demand webinar that you may share with others. You should receive that tomorrow. Both the recorded webinar and this slide presentation will be posted on our website tomorrow. And the full CAQH Index report is available on our website this afternoon, www.caqhindex.org. Your phones will be muted throughout the presentation. All questions should be submitted online. And you can ask a question at any time today throughout the session. Just type your question into the right hand of the side of the go-to webinar panel. And at the end of the presentation, we'll be addressing those questions. So now I would like to introduce today's presenters. They are, first, Elizabeth Ormson. She is Senior Statistician in Statistics and Methodology with NORC at the University of Chicago. And from CAQH, we have Raynard Washington, the Senior Manager for Research and Development. Now let me turn this over to Raynard.
Great. Thanks, Karen. So thanks everyone for joining us today. We appreciate your attendance at today's webinar. We have quite a bit to get through, so we're going to move as quickly as possible and try to give you a very high-level, yet detailed overview of the findings of the 2016 Index report. As an agenda, just so you guys can see on the screen now, we'll start with a very brief overview of CAQH, what the organization is about for those that may not be familiar, and then we'll shift in to talk a little bit of background about the index, and then we'll get into the key findings and some of the feature focus for the index in 2017. CAQH is a nonprofit organization that works primarily with health plans and healthcare systems to streamline the business of healthcare. We work in three large domains to be able to address how healthcare is administered in our country. The first area, which is in the top circle, is national business rules, and many of you may be familiar with CAQH Core, which works to develop and implement operating rules across the country in the industry. By convening industry stakeholders from various sectors to develop these rules to be able to maximize efficiency in how the HIPAA transactions and standards are implemented in the industry. We also have our solutions team, which develops shared utilities that both health plans and healthcare providers can use to be able to help to foster and facilitate some of the interactions that happen between those entities and really help to try to streamline both, particularly around provider data management and also some areas with membership data. And lastly, we have the industry research area, or thought leadership, that basically collects information across the industry, various data sources that we use to be able to establish and serve as a catalyst for the industry in terms of knowledge to help us make better decisions about efficiency and obviously administrative simplification. On the next slide, we see some of the very specific initiatives that you may or may not be familiar with that CAQH has. I've already mentioned the core team and the work they do with operating rules. There's also the CAQH Index, which falls under the explorations area. that we're here to talk about today. But we also have initiatives like Purview, which is a provider data management utility that basically has data from over 1.4 million providers that's linking those individuals and entities with health plans for the purposes of credentialing as well as directories, and so forth and so on. So get into the meat of the matter for today. We're going to be talking about the index. So what's the index? The CAQH Index is a voluntary nationwide survey of commercial, medical, and dental health plans and healthcare providers. So each year, CAQH surveys a large, robust group of health plans, which I'll talk about in just a second how many, as well as healthcare providers, to get information about their transactions that they're transmitting on an annual basis. It's the only industry source that's really tracking the adoption of the full adoption of electronic transactions. And when we talk about electronic transactions, which I'll show in just a second, we're really talking about those interactions that happen between healthcare providers and health plans that are centered around the claim cycle and being able to provide billing and receive payment for care that's given to patients. Tracking the progress of adopting these electronic transactions is very critical, and it really helps us to be able to further understand where we have clear opportunities for improvement and where the industry is making the most progress. The CAQH Index is guided by an advisory council that's made up of stakeholders that represent various groups across the industry, both health plans, healthcare consulting organizations, industry thought leaders, and that council is very critical in our decision-making process as we decide what areas the index explores, as well as making sure that the findings from the index are well taken up by the industry. So why does this all matter? About 2 decades ago, as many of you probably know, HIPAA established rules for the adoption as well as the use of electronic transaction standards. These transaction standards were really meant to serve as a replacement to the resource-intense manual processes that many providers engage in on a regular basis to be able to interact with health plans. These include things like submitting claims, checking a patient's eligibility, getting paid by a health plan for care that's been submitted, that's been provided, as well as getting prior authorization for medical services. The industry stands to save lots of money by transitioning from manual processes to conduct these basic interactions to electronic, automated, standardized transactions that would be most efficient and most cost-effective way of accomplishing those tasks. This transition is a critical component of the modern healthcare system. As the system itself evolves and becomes more automated, having the basic back office processes also be automated serves to gain tons of efficiency as well as cost savings for the industry. A couple of critical points here. It reduces unnecessary healthcare costs. It really eases provider administrative burden. We'll talk about later some of the estimates of the amount of time that providers are wasting doing manual processes. It reduces some friction between providers and health plans because it allows their interactions to be much more seamless, as well as allows their interactions to be much shorter in terms of time and effort that's spent to conduct them, as well as it reduces the amount of errors that occur. And as I mentioned earlier, it also complements the revolution of clinical use of healthcare IT and certainly provides for the industry an integrated healthcare ecosystem in terms of automated processes. So moving forward to the next slide, to know who participated in the 2016 index. We are very grateful for the many health plans and healthcare providers that participate on an annual basis in the index. As I said earlier, we do survey them annually. For health plans, we include individual and group coverages. So these are commercial, medical, and dental health plans. And it includes from those plans their managed care and managed Medicaid and managed Medicare product lines as well. For the health plans, for the medical health plans, based on the AIS's directory or annual survey of health plans, we estimate that we have about 46% of the commercial medical industry represented in the index. Similarly, we think we have about 44 to 46% of the dental health plans represented as well. So we think we have a very representative set of health plans participating on an annual basis. Of note, we have observed a significant increase in enrollment over the last 4 years. for plans that are participating in the index. So that obviously, as more individuals in our country are getting coverage, we would expect to see increase in membership in the plans that are participating. We partnered with NORC at the NORC at the University of Chicago to manage the provider data survey. That survey essentially receives data from a large and diverse sample of providers that represent a variety of specialties, but also a variety of practice settings. So we do have healthcare systems represented, we have academic medical centers represented, dentists, community healthcare centers, behavioral health centers. So it is a very diverse sample of providers, and so we think we do have a very nice mix of entities that are represented there. So I talked a little bit earlier about the transactions that we're currently analyzing. This slide shows you all the transactions that are in the data collection process. And as we continue to, CAQH acquired the index about 4 years ago, and over those 4 years, we've been working very diligently to evolve the robustness of the data that we collect. And so we've added, over the last 4 years, we've added several transactions to the core set of transactions that we collect. And this slide shows you that the transactions that we're currently collecting data from our contributors on. The slide also shows, it also marks for you which of those transactions have a HIPAA standard associated with them, as well as operating rules, which are at this point, for those certain transactions, fully mandated. So shifting now to talk about the findings of this year's report. So first I'll talk about adoption of electronic transactions, then I'll shift to talk about cost. So for the adoption estimates, participating health plans report to us the aggregate count of administrative transactions that are conducted in the previous calendar year. So for the 2016 report, the data actually reflect calendar year 2015. So all these transactions that were conducted in 2015. And they report to us the number of transactions by both type of transaction and also by method. And so when I say method, we classify our transactions in 3 categories. The first is fully electronic, and these are transactions that are conducted using the adopted or mandated HIPAA standard. The second is partially electronic, and these are transactions that are conducted between providers and health plans that are partially electronic because for the healthcare provider, they're still manual, but for the health plan, there's some level of automation. And this is in the form of either health plan-sponsored web portals where a provider can log in, and the provider still has to do more work on their end, but it interacts with the automated process on the health plan side, and also such as the interactive voice response system, which is an automated phone system. And then the last category we use is fully manual. This category is essentially the most resource-intense category that we believe, because it requires human-to-human contact on both the provider side as well as the health plan side, and that typically comes in the form of either telephone or paper that's sent via fax or postal mail or maybe even email. So this first slide, the next slide, shows an overview of where we are with adoption for over the last 2 years. In general, trends show a steady but modest increase in adoption of fully electronic transactions. And for some of the transactions, we do see some promising accelerated growth that's occurred over the last 2 years. On average, adoption of electronic transactions were lower for the commercial dental health plans, and we reported dental health plan adoption for the first time, or dental health adoption for the first time last year. And we still see that the trends are relatively low, but with some promising increase across each of the transactions for which we can report. It's important to note here that we don't have adoption estimates for all of the transactions, and that's because of reporting limitations from our participating health plans. So either we don't have sufficient data from the plans to aggregate across them all, or we don't have a sufficient denominator to be able to estimate what the adoption levels are. But you'll see on this slide for the medical plans, we do, claim submission continues to have the highest adoption level, and referrals and prior authorizations have the lowest adoption level for the medical community. And for the dental plans, similarly, claim submission has the highest adoption level, but unfortunately, claim payments for the dental health plans, which we'll talk about a little shortly, is relatively low and significantly lower than it is for the medical community. So just to talk a little bit more detail about some of the adoption trends that we've noticed over the last 2 years. So for eligibility and benefit verifications, as well as claim status inquiries. So claim status inquiries are when a provider has submitted a claim and they're trying to now check with the plan to see the status of that claim. The use of electronic transactions is increasing very rapidly. But we've noticed that even though we've seen a really large increase in the volume of electronic transactions, we haven't seen as a similar decline in the volume of manual transactions. So that is, while, for example, as you can see from this table, we've seen a 44% increase in the volume of electronic eligibility and claim status inquiries, but we haven't seen a comparable decline in the manual telephone calls. So the volume is increasing very rapidly, but we're not seeing the call center calls go down as rapidly. There's some reasons why we speculate that this large increase in electronic transactions is occurring. Obviously, with coverage expansions that have occurred, there are more complex coverage types, such as high deductible plans, and so there may be a need for providers to check a patient's eligibility more often than it has been in previous times. Also, there are now practice management systems that providers use to coordinate their back office functions that have the capability to basically routinely check eligibility for patients, whether or not the patient's there for an encounter or not, and also has the ability to check the status of all outstanding claims, which in fact may be causing this large increase in electronic transactions. And similarly, we may not have the comparable number of providers who are not using the telephone to call, and so that's why we're seeing the trend that we're seeing. Next slide talks a little bit about adoption of EFT. This year, we only noticed a slight increase in adoption of electronic funds transfer. This may possibly be related to, I must note here, a caveat is that some of our health plans observed lower rates this year than what they had previously estimated, and it's mostly as a result of improvements they've made to their tracking mechanisms. So some of this low increase in EFT may be related to an overestimation in previous years, but we do believe that we have much more precise estimate now. So we didn't see a large jump in EFT. And of course, EFT is payment for a claim that's been submitted by a provider. On the other hand, we did see a steady increase of about 4 or 5% in electronic remittance devices, up to 55% from, I believe, 51% last year. I must caveat, though, that a third of these remittances are still sent manually, so still definitely an opportunity for improvements there. We do note in the report that some of the increase in ERA adoption may be related to the implementation and regulation of operating rules in 2014, which these do provide for the industry uniform specifications for the denial and adjustment codes, and require the association of the ERA with the payment. And so this might be affording providers and plans some efficiency. It's likely affording them some efficiency that may be encouraging them to use electronic transaction versus receiving a paper remittance. The last thing I know, for the first time this year, we're really excited to be able to report estimates of adoption of electronic remittance devices for CMS. The index has not historically contained any data from the public side in terms of either publicly sponsored Medicaid or from CMS Medicare. And so this year we were able to work with our partners at CMS and thank them very much for being able to provide data on adoption of ERA for Medicare. For the first time this year, CMS reported 85% adoption of ERA for Medicare's Part A and Part B, which has shown a very significant increase from their estimates from 2005 and 2014, which were at 31 and 81% respectively. So it appears that CMS is performing at a rate higher than the commercial industry. CMS also, two things we'll note, CMS does, Medicare does have provider EFT requirements for some subsets of providers, and so providers may be more likely to be enrolled in EFT because of the regulation. And also CMS provides for providers a free, easy Medicare Easy Print remittance tool that converts an A35 transaction to an easily read or machine-readable PDF file. So those tools may be encouraging providers to enroll and to receive those transactions electronically. Moving forward here, just want to take a second and talk a little bit about prior authorizations. There was this year in 2015, for the first time since the index has been in existence, a very sizable increase in adoption of electronic prior authorizations. The prior authorizations and referrals still have the lowest overall adoption of electronic transactions, but we did see some promising growth this year. And this growth is likely related to the industry-wide attention that's being paid now on the prior authorizations for medical services and how they're being managed, and particularly because prior authorizations, as many folks know, are one of the most costly manual processes that providers have to complete as a result of the need often for attachments and additional paperwork to be able, and time that it takes to wait for a response. Participating health plans did report significant investments in improving how they manage their prior authorizations, trying to particularly streamline how prior authorizations are integrated into provider systems, and also plans reported working to automate the review process of requests, which greatly reduces response times for providers. We also spoke to several practice management and clearinghouse vendors this year, and several of them reported their efforts to create and expand systems that support electronic submission of prior authorization. And then also, just as an industry trend, some health plans are limiting the number of medical services that require prior authorizations, and as such, the volume of prior authorizations may not be growing. We do receive also, in addition to prior authorizations, information about referrals from a subset of our health plans. Referrals are essentially requests from or notifications to health plans about a primary care provider in most cases referring a patient to a specialist of some kind. Several plans don't actually require referrals, and other plans don't actually have separate tracking capabilities. But we did note that referrals had a relatively low adoption of electronic transactions, but over 86% of referral requests are submitted using web portals. And similarly for prior authorizations, about half of those are submitted using health plan-sponsored web portals. And so there seems to be obviously an affinity to use of those methods, which certainly saves resources for plans and providers to have at least those web portals as a resource. Next, I'll talk about claim attachments. For the first time this year, the index is reporting adoption of electronic claim attachments. We estimate that about 6% of healthcare claim attachments are submitted to medical health plans electronically, with the rest being sent manually. This estimate is the first time we've ever reported this, and it's important for us to note that this is somewhat isolated, as most of our participating health plans reported that 100% of their claim attachments come in manually, and very few reported any use of electronic claim attachment at all. So it's clearly an opportunity for industry action to put some efforts around claim attachments. There have been some activities in the industry. NCVHS recently recommended that HHS adopt a version of the HL7 standard for claim attachments. I will note that in the index, the responding plans only reported use of the X12 standard for claim attachments to date. So we didn't get any reports of plans receiving the HL7 standard, despite the fact that that is has been recommended as an industry standard. The other point I'll make here is that meaningful use requires electronic health workers to use the HL7 standard for clinical attachments that go into the electronic health records. We don't currently have any good estimates of how many people are using the CCD Plus, though it's required, and so there's no industry benchmark, and so that's also another opportunity for further inquiry. As most claim attachments do require some information from the electronic health record, it's important to be able to understand how the interoperability between the practice management system and the EHR are functioning if we want the industry to move towards a point of having individuals submit their claim attachments electronically to the plan. Lastly, I'll talk a little bit about enrollment and disenrollment transaction. I think we mentioned this on last year's webinar as an opportunity for the industry. We have heard from varying industry stakeholders that the level of adoption of the enrollment and disenrollment transaction, which is basically the transaction that's used to send information from a payer, from a employer to the payer, or from a broker to a payer about members. So it's membership information about when members change their contact information, when members change their enrollment status. It allows the electronically to communicate to the plan those changes of information. Given we've gotten several reports from various industry sources, but at this point we are not able to develop a benchmark of adoption of this due to some of the data reporting limitations that currently exist, and we're actively working on these. But given that there are some inconsistencies, there's some health plans that are reporting very high use of the 834 transaction. There are other health plans that have reported no to limited use of the transaction. It's really important that we, particularly the index, moves towards establishing an industry benchmark for this transaction because we don't have a true reliable estimate at this point. I can tell you that based on preliminary data from just one of our health plans that participates, utilization of the transaction was fairly high. Nearly 50% of the enrollment, disenrollment, transactions were conducted electronically using the transaction. But this experience of this single plan is not sufficient for us to actually report industry-wide adoption levels. So we really are going to work in the future and this year and next year to really be able to try to overcome some of these adoption barriers that are listed here on the slide to be able to report the adoption of the 834 transaction in the future. Okay, now shifting to the cost. So the two things that the index focuses on obviously are cost and adoption and cost. So just as a note, we have historically reported costs for several of the transactions, in most cases a subset of the transactions. In 2015, we reported the cost estimates that we reported only represented a fraction of the true industry savings opportunity associated with adoption of electronic transactions. We included just the direct labor costs for only 6 of the 12 key transactions that we're currently studying, and the costs were only for medical health plans and providers. So this year, the index, with its commitment to always continue to grow and expand, we added a couple of components to our cost estimate. The first one is we include now costs for claim attachments, which we have not previously included. In addition to the claim attachment costs, we have cost estimates from plans that offer dental health plans as well. So as a result, we were able to develop potential savings opportunities for the commercial dental industry for just the 4 transactions that we currently are able to track adoption for. And the last thing that we did was we added a component to the survey that basically explores some of the practice management system and provider-facing clearinghouse vendor fees and pricing models, so that as we think about the total cost of conducting a transaction, we're able to better estimate some of those overhead costs in future and later reports. Okay, so to produce the health plan cost estimates, we essentially, participating health plans provide for us a cost per transaction. These costs are weighted and then averaged based on the health plan's transaction volume. The health plans use a variety of internal reporting systems to estimate the fully loaded direct costs for each transaction. And they estimate these costs by transaction type. So we include staffing, including the number of employees, the salaries of those employees, the volume of transactions, as well as the percent of time that they spend conducting each of those transactions. And our health plans actually are able to, in many cases, integrate some of their back office vendor fees that are related, that allow them or help support the conduct of these transactions. So now I'm going to turn over to Elizabeth for just a moment to talk a little bit about our healthcare provider survey and present some of the results from the healthcare provider side of the survey. Elizabeth?
Thank you. So NORC was responsible for recruiting the healthcare providers for the 2016 CAQH Index. So we did this through targeted email and telephone outreach to a broad range of providers that represented a variety of specialties and different practice settings. The data collection itself was completed from August 2016 through December 2016, again reporting on 2015 data. The responding provider organizations were given a fillable questionnaire that they filled out. A follow-up interview was scheduled just to make sure that we understood the details of what we were given, and in some cases, we actually did site visits. The healthcare providers use a variety of different reporting systems to estimate and to give us information around, as Raynar said, staffing, so the number of employees working on these specific transaction types that we were interested in, but then also the salaries associated with those employees doing that type of work. And lastly, talking about the transactions, both the volume of transactions, so by type, claim submissions, prior authorization, but then in particular by mode, so electronic versus manual. And one of the new things that we added this year was actually asking for the amount of time spent on processing each transaction type by mode, looking at the actual minutes that were spent. So on average, healthcare providers spend approximately 8 minutes and up to nearly 30 30 more minutes processing each of the manual transactions compared to the amount of time that's required to process an electronic transaction. So a large differential there. We're estimating that at least 1.1 million labor hours per week could have been used more efficiently, providing patient care, doing other clinical tasks, if they were to achieve full adoption of electronic transactions with only the following 6 of those 12 different transaction types that we tracked. So for example, if you look at the table on this page, looking at the claim submission and receipt, we show the average number of minutes to process a manual transaction claim submission is 5 minutes, whereas compared to electronically, it's only 1 minute. So a difference of about 4 minutes spent on each claim submission transaction. And you can see there's this standard difference, obviously, between electronic and manual transaction types, ranging from just the 4 minutes for a claim submission, but up to a differential of 14 minutes for prior authorization. So on average, each manual transaction costs the healthcare providers approximately $4 more than each electronic transaction, so a slight increase from what we saw last year. But while similar, the cost estimates for 2016, they do reflect this increase in the potential cost savings for providers, but these differences may not reflect a true trend in cost over the years, but likely are related to improvements in the survey methodology that resulted in better estimates this year. So this included modifications to the survey instrument and structured interviews with the responding providers. So again, focused on the table, if you look at the claim submission receipt, the provider cost for a manual claim submission is approximately $2.02, whereas the associated cost for an electronic claim submission is just 59 cents, so a differential of $1.43. So again, across all of these transactions, that's quite a large savings across the industry. So I'll turn it back to Reynard now.
Yeah, so similarly, we estimate, as I mentioned earlier, the same cost for health plans. On average, the manual transactions cost health plans about $3 more than each electronic transaction that they conduct. And this varies pretty substantially across the transactions, from the potential cost savings being as low as 48 to 45 cents for claim payments and remittances to send those to providers, upwards to for around $4 for eligibility and benefit verifications, prior authorizations, and claim status inquiries, where it takes obviously more time on the health plan side to receive those transactions. I'll make an important point here. The index does not track all of the costs associated with the transaction itself. So we track the direct costs associated with transmitting the transaction, but as you all know, for many of these transactions, there may be additional follow-up that might occur, there may be additional review on the health plan side, and so these costs don't include some of those indirect costs that are associated with conducting business between the plan and the provider. So we do believe that these are actually probably underestimates of what the industry really could actually save if we were to accomplish full adoption of electronic transactions. Flipping over to the next slide, we basically see from an industry viewpoint, if we combine, because every transaction, there's a sender and a receiver. So every time you send a claim, the health plan has to receive it. And so it costs both the provider and the plan to complete that transaction on both sides. And so if we combine the potential cost savings across the industry for both the plan and the provider, we see that the savings opportunity for any one transaction is fairly substantial. So for one single claim submission, the industry could stand to save nearly $2 across plans and providers. And if you think about the billions of claims that are submitted on an annual basis, this is a fair amount of money. The largest savings opportunity for the industry has and continues to be prior authorizations. And these transactions, as I mentioned earlier, often require attachments and additional levels of effort to be able to get from the provider to the plan. And the industry could save over $9 per prior authorization that's submitted on an annual basis. And given the low adoption of electronic prior authorizations, this is a true opportunity for industry to save resources. Moving over to the next slide, the next thing we do with the cost estimates is we take our adoption estimates and we basically say, based on the representativeness of the plans that are in the index, how many transactions do we estimate actually occur in the industry? And those estimates are included in the full index report. So if you're curious to know how many claim submissions we estimate are happening in the commercial space on an annual basis, you can see those in the full report. But what we do is we take the total number of transactions for our plans, we extrapolate those up to the industry, and then from there, we take the distribution of manual electronic, and we say if all those manual transactions were conducted electronically, how much could the industry possibly save on an annual basis? And based on those estimates, when you do all the math, the potential cost savings from adopting these just electronic processes for these 7 transactions for the medical industry is over $9.4 billion, and for the 4 transactions that we track for the dental industry is $1.9 billion. And this is in direct cost that we could potentially save on the commercial side each year. This does not include even the public payer side, and it does not include all the transactions in the claims process. And so this is a large amount of resources that could be saved, but it is truly not a full reflection of all the resources that could be saved by automating more of the back office functions in the industry. The largest savings opportunity for the medical industry is eligibility and benefit verifications at about $5 billion each year. And of course, as I described earlier, the reason why there's such a large opportunity with eligibility and benefit verifications is because it does require, in most cases, end-to-end human contact, with telephone calls being the primary manual way these are submitted. And then there's a large volume of them on an annual basis. Last year, just in the health plans that are in the index alone, they fielded over 72 million calls just to check a patient's eligibility. Next slide. As I mentioned earlier this year, we also looked to explore some of the practice management system and provider clearinghouse vendor costs for providers. These are necessary tools to be able to conduct the transactions electronically. The practice management system, of course, is the software the provider uses in their practice or office or facility. And the clearinghouse is an entity that sort of sits in between the provider and the health plan, and sort of acts as an intermediary to ensure that the transaction is clean and successfully gets to the plan. They have fees, and so we wanted to understand so that we could fully estimate some of the overhead costs associated with both electronic and manual transactions, what those fee structures look like. This year we began that effort. We interviewed over 16 vendor entities that provide these services. We provide in the full report an overview of these services and how their pricings are structured, and we hope that next year we'll be able to integrate more of the overhead costs for both the manual transactions as well as for the electronic transactions, so that we can continue to expand the cost estimates that we currently have in the index. So with all this very interesting and exciting data, we would not be remiss to not take the opportunity to really state some clear actions that we believe these data support as industry opportunities for action. The industry has made significant progress and continues to make real progress in adopting electronic transactions. We're seeing the volume of electronic transactions increase very rapidly on an annual basis, and so for us, that's obviously great news. And in many cases, in some instances, we're seeing the volume of manual transactions trend similarly downward. But we do believe that there's still significant opportunity to save not just that $9.4 billion, but even more that we may not be potentially estimating here in the report. Some key areas of action that we recommend, and I believe these data support, are that the industry must continue to share and expand best practices in order to increase adoption of electronic transactions, and really stop providers and other entities from relying on these resource-intense manual processes to basically allow the industry to move forward. And so we believe that the industry as well as the government has a responsibility in leading outreach and educational activities for both health plans, healthcare providers, and their intermediaries, such as the practice management system vendors, to ensure that both the transactions are being used, the standards are being complied with, and the operating rules are being implemented to ensure maximal efficiency as these interactions are taking place. The second area of action we believe is important is that we must continue to increase industry-led efforts that really reduce adoption barriers for health plans and for healthcare providers. And this includes considering possibly financial incentives for either entities, as well as implementing or instituting contractual requirements to ensure that providers and health plans are using these standardized operating rule compliant transactions. And the last area that we are very much and explorations area committed to is continuing a systematic review of business processes. And the core team here at CAQH is also committed to this effort to ensure that we are using the most efficient way, ensure that we have operating rules for all the transactions, we have standards for all the transactions, and to ensure that those operating rules and standards are in fact up to date, efficient, and in fact actually are the most efficient way to reduce and maximize the cost savings. And the last point I'll make is, as the national benchmark, the index will continue to evolve each year. We continue to welcome suggestions and advice from the industry at large about what information is necessary, what would help the industry and help drive the actions that we are suggesting, as well as other areas for exploration and opportunities for us to continue to track and establish benchmarks. So before we shift to the question and answer period, I'd just like to open the floor to provide information that we are going to have a 2017 CAQH Index. And so if you are a health plan, a healthcare provider, or a vendor organization, there is an opportunity here for you to participate. My contact information is on this slide, and we will be posting participation information on CAQHindex.org. But there is an opportunity for plans to participate and providers by completing our annual surveys and providing data for us for calendar year 2016, as well as vendors have a plan to participate in the vendor survey, as well as to share the call for data submissions with your constituents or your clients, so that they might participate and make our data even more robust. As an incentive, all of the participants do receive company benchmark reports that compare your estimates to the industry at large and similar entities, as well as it tells you, an estimate of how much efficiency opportunity your company would have by adopting fully electronic transactions. So with that, we'll shift to our question and answer period. If you have questions, as a reminder, you can just click on the questions tab to the right, and you're able to type in your question, and I'll just read them off and try to answer at the same time.
We have received several questions about whether or not the webinar will be recorded. Yes, it will be available tomorrow on www.caqhindex.org. Everyone that registered for the webinar today will also receive an email thanking you for your participation and including a link to that recorded webinar, along with the PowerPoint slide presentation by itself, and also the complete CAQH Index report for 2016. So that's a question that's come up several times.
Okay, so I'll just start with at the top of the questions. So one of the first questions we have is, let's see, does the index currently track or have resources available on transactions conducted with pharmacy organizations? No, the answer to that is no, not at this point. The index has not. We've historically only tracked information for interactions with healthcare medical service providers and dental service providers and the health plans. We have not actually looked into tracking for the pharmacy, but that is something that we certainly could consider as we think about. There are, of course, administrative transactions within the pharmaceutical industry or pharmacy space that we could potentially consider. So thanks for the suggestion, and we're not yet there. Our next question is, does the data include attachments for healthcare services review? This does not seem to be a part of the assessment. The information that we are including the question is really about, do we include data on prior authorizations attachments? We, at this point, do not have sufficient data from our participating plans to specifically report information on prior authorization attachments. And so we have not actually created a national benchmark yet for adoption or cost of prior authorization attachments. So the attachments that are here just reference or refer to the attachments that are combined with the healthcare claim. Okay, next question we have. You mentioned that there are adoption barriers for providers. What are the biggest adoption barriers for healthcare providers? I think that's a great question, and actually I'll start the answer, and I'll actually let one of my colleagues chime in, Aaron Weber, who works on our core team and let her give her some comments as well. But healthcare providers that we work with in the index do report several barriers to adoption, either as it relates to the not having the systematic capacity to conduct the transaction, so they don't have a practice management system that's able to conduct, and either for financial reasons or other reasons have not upgraded their system, or they may have legacy systems that don't have the capacity to do so. Other barriers that we've heard from some of the providers that participate in the index is they either may have some sort of understanding or they may have not be able to properly understand or interpret some of the information in the transaction, for example, with eligibility. So they still rely on using a telephone. Other things are, it's just provider behavior in terms of their decision making. And some of the things that we're planning to do in this year's index is to try to better understand some of those decision making that's happening in the provider organizations as it relates to when they make a decision to either conduct the transaction electronically or to, for example, pick up the phone and call. Erin, I don't know if you want to chime in and a couple of things from the core team perspective.
Sure, Raynard. I think you actually covered the key barriers. I think the capacity of the practice management system and the revenue cycle systems to conduct transactions electronically in accordance with the 5010 version of the standard, as well as the mandated operating rules, is essential, and that's still a challenge. So we often are encouraging providers to reach out to their vendors to better understand the details of their system and if their system is operating in compliance with the standards and operating rules. So that is definitely the first step. The only other item that you didn't mention, but we're hearing this less and less than we were even 5 years ago, is concerns specifically with the EFT transaction around sharing banking data, but that's really not something I've heard as commonly as we did 5 years ago. So I think comfort level with that information is improving.
Great, thanks, Erin. Another question that I think you might want to chime in on as well is some of the health plans are establishing projects to automate healthcare claim attachments in future years to come. Do we have any thoughts about the timing of mandates for health electronic claim attachments and when there might be any potential requirements coming along?
I may ask my colleague Bob to chime in on this one because I think he's been tracking it a little more closely than I have. The National Committee on Vital and Health Statistics did come out with a recommendation for the Secretary of HHS, I believe it was last year, on a set of potential standards for electronic attachments. But as of now, CMS and HHS have not put forth any regulation related to an attachment standard. And as we all know, with the transition happening with the administration right now, this may not be a key focus in the immediate future. Bob, do you have anything to add there?
Yeah, I'd like to add that CAQH Core is actually sponsoring a webinar series on attachments this winter and into spring. So look forward in the next couple of weeks for our first announcement on the attachments webinar. We'll be working with the industry at large on exactly what types of standards are being used today, what different communities and stakeholder types are using and how they're conducting the transactions for attachments, both with claims as well as with prior authorization. So it is a hot topic, and we are definitely all over it. So look forward for some more information.
Great, thanks, Bob and Erin. We have another question here. It says, will future surveys take into account the cost associated with partially electronic transactions as well as other components of the electronic cost? Yes, and so one of the things that we're working towards this year is to also understand if there is a cost differential between the effort that goes into using, for example, a web portal and the effort that goes into conducting the transaction electronically through the practice management system. I'll also say we are looking to, as I mentioned earlier, to add in the practice management licensing fees and have an estimate of those, as well as the clearinghouse fees, which are the practice management fees are typically a license or a subscription per user, and the clearinghouse fees typically are per transaction or per volume of transactions. So we're hoping to be able to add in some of these overhead costs, not just for the electronic, but also for the manual. So estimating, what are the overhead costs associated with the telephone call, as well as, faxes, and then have a comparison of the overhead costs so that we can be more estimating not just the labor components, but we can get a more fuller picture of what the expenses are related to conducting the transaction. Next question is, are transactions that are conducted via a clearinghouse included in the estimates for the index data? Yes, the answer to that is absolutely. We do have transactions that are conducted via a clearinghouse. The one caveat that I'll note that's also noted in the index report is clearinghouses sometimes and in some cases do not receive transactions manually from healthcare providers. And then depending on the clearinghouse, they may actually, or the system that's set up, they may convert that manual transaction to a standard transaction. And so, in fact, that transaction is received by the health plan using the electronic standard. And so, for the cases of the index, those transactions are, in fact, counted as fully electronic because we don't have a way of distinguishing between those transactions that come via a clearinghouse and those that come directly from the provider. So, in fact, if the provider is sending it manually to the clearinghouse, then we do capture it, but it's going to be captured as fully electronic. And we continue to work with our plans to try to understand how we might be able to institute data trackers to understand and distinguish between those instances, because of course that does still add another layer or step in the process for the provider, and it's not the fully electronic end-to-end automation that we would obviously hope for. A clarifying question here, are the claim payment is the EFT and claims remittance at 835 being sent to the provider correct? Yes. So the EFT that we track here is the electronic payment to the provider. This year, which we did not discuss in great detail on the webinar, but we do report for the first time adoption of virtual credit card payments. We believe adoption of those payments, those are not the HIPAA standardized payment. The ACH payments are the HIPAA standard for electronic payment. And so that the EFT does just include those, the estimate that we have, the 62%. But we also have another estimate this year that includes the virtual credit card payments, which is at about 1% or less. And then we have an estimate for the paper checks. And the same for the remittance. We have the 835, the electronic payments are the ones that are presented here, as well as those that are sent via web portals and manual are also presented in more detail in the report. We have a couple more questions about whether or not the report and the webinar are going to be available. They will all be available following the webinar at CAQHindex.org. The webinar itself, the recording of the webinar will be available tomorrow, but the slides and the actual report will be posted just immediately following the webinar.
As a reminder, you may enter questions at any time using the space on the right-hand side of your screen. Please enter your question, and we'll be happy to answer it.
Great. Another question. Do you foresee a time in which paper will simply be not accepted by insurers? I think that's a very interesting question that we could probably have a very long conversation about. But I will say that there are requirements, HIPAA requirements, as well as some associated with the Affordable Care Act, that basically require providers and health plans and any HIPAA-covered entities to utilize these electronic standards that we've been talking about all day. And so those requirements obviously are trying to push the industry towards a place where everyone's relying on the electronic transactions and not using the manual transactions. Will there ever be a time where we'll realize 100% electronic for all of the transactions? I can't predict that. It may not be a realistic target or goal. I think the industry broadly has been at about over 95% adoption of claim submissions sort of broadly across the industry for a very long time. So to say that we'll ever get to 100, I can't say for sure, but I do think that that's a very plausible question. And whether or not the industry utilizes requirements or regulations to move providers and plans to that point, I think that's for the industry to figure out. And CAQH is obviously here to help facilitate some of that process, and obviously developing these, convening stakeholders across the industry to develop best practices to move us forward. Next question, are there any specific barriers that you would like to, that you're hearing that are related to prior authorization adoption as a significant opportunity in the industry? I'll comment briefly, and then I'll let Erin talk a little bit about the work in prior authorization that's happening on the core team. We do hear from our providers, of course, that many prior authorizations, as was asked earlier, do require attachments. And as those attachments are necessary, many providers choose to utilize the health plan sponsored web portals to be able to submit the attachments and the actual request at the same time. Other barriers would include obviously not having a practice management system that can support submitting both the prior authorization transaction as well as the attachment. And many of the practice management system vendors we're hearing are just starting to develop solutions within their products to be able to support the electronic transmission of those transactions. So if a provider doesn't have the capacity to do so, of course, they will have to use alternative methods. And then even as those capacities are rolled out and developed, if provider behavior is sort of keen to using a web portal or a fax machine, then it will be a matter of education and outreach to encourage individuals to transition from their former methods to the newly available methods using their practice management software. Erin, do you want to comment just for a second about some of the prior auth things that you guys are hearing on the core side?
Yes, CAQH Core has identified prior authorization as a priority focus area for 2017. As such, particularly for those organizations that are on the line that are core participating entities, and if you're not, we would encourage you to join so you can get involved in this work effort. We have a small advisory group looking at a set of prior authorization opportunity areas related to operating rules. Right now, they are conducting an environmental scan, trying to get a better gauge on what are some of these barriers through site visits, interviews, surveying. There's currently a core participant survey open on prior authorization opportunities to help prioritize what the direction should be for the industry to go. So ultimately, CORE will be launching a subgroup probably in early spring, looking at a well-vetted list of opportunities based on all of this research in the environmental scan to consider whether there are true opportunities to pursue operating rule development for. So definitely more to come, and to hear updates if you are not a CORE participant on that work effort, we'd encourage you to register for the CORE Town Hall calls, which are held on a quarterly basis.
Thank you, Erin, and also thank you, Renard and Elizabeth, for leading us through today's webinar. This does conclude our CAQH webinar. As a reminder, again, you're going to receive an email which will have links to the report and the recorded webinar that you may also look at via www.caqhindex.org. Thank you so much for joining today, and goodbye.